Yes, sir. 3, 2, 1, start.
Thank you. Very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on a recent update in PCNL surgery. This will be presented by Dr. Sarthak, our resident, and would be moderated by our faculty, Dr. Manoj. So I would request Dr. Sarthak to kindly share his presentation. This one. That's it.
Good morning, everyone. I'm Dr. Sarthak Sharma. I'll be presenting this seminar on recent updates in PCNL. PCNL, how it evolved. In 1941, Ruppel and Brown were the first world to do a nephroscopy during an open surgery via a rigid cystoscope. Then Goodwin in 1951 is credited with the first nephrostogram. He was doing a renal biopsy and accidentally entered into a PCS. And that's how he performed the first nephrostogram. And during that, he found pus and placed first nephrostomy, and first nephrostomy was done by him. Bernstrom and Johansson in 1976 are credited with the first extraction of renal calculi via an already placed PCL, while Arthur Smith in 1978 is credited with the first integrate stenting. He also gave the Gibbons stent in a reimplanted ureter. PCNL, PCNL is considered a first choice treatment for renal stones of more than 2 centimeter. It shows better stone-free rates as compared to the shockwave lithotripsy and RIRS. Coming to the advances, the major advances have been in the miniaturization of the endoscopic instrumentation, with standard PCNL having an outer sheet diameter of 24 to 30 French, with mini PCNL having a outer sheet diameter of less than 22 French, ultra mini with 11 to 13 French outer diameter, and Superbug, which is the more recent one, using a 10 to 12, now been modified from 12 French to 24 French of sheath, and micro PCNL utilizing the smallest 4.85 French outer diameter sheath. Coming to Minibug, Jackman SV in 1998 performed the first mini PCNL in children, following which Rahim in 2001 performed first mini PCNL in adults. The axis has been fluoroscopic as well as ultrasonographic, and the sheath used is usually less than 22 French. Nephroscopes of different sizes have been used, more commonly 12 French is used. Coming to the comparison, mini PCNL when compared with a conventional PCNL shows 21.4% less cross-sectional diameter. And if you see the instruments and see, there is a working channel which is quite smaller as compared to the standard nephroscope. Coming to ultra mini PCNL, it was given by Desai et al. In 2013. And it consists of a 1 millimeter of telescope with a 6 French inner sheath having 2 channels, one for instrumentation, one for irrigation, and an 11 French outer sheath with a side port. It utilizes the laser lithotripsy with a setting of high energy of 12 watt and low frequency of 8 Hertz. This is a videographic representation of ultra mini, in which after initial axis guide wire is placed, following which dilatation is done. Then here laser is used for fragmentation. The important point to note here is that after fragmentation, we inject normal saline and the fragments are removed by a whirlpool effect. Indications. It is indicated up to renal stones of 2 centimeters, and to complement the standard PCNL where there is a stone in a difficult calyx. Advantage is there is a special design of working sheath for stone fragments retrieval without baskets or graspers, and it shows good stone-free rates. Micro PCNL, it was given by Bader in 2011. It utilizes a 4.85 French all-seeing needle, which has 2 outlets, one for laser fiber and one for irrigation channel, and utilizes 0.9 millimeters of flexible telescope. Important here is flexible telescope. It has a retrograde attachment because the needle cannot withhold the heavy weight of the instrument. It is a one-step procedure where dilatation and guide wire insertion is avoided and only laser lithotripsy can be used. Stones are not removed, only stone dust is made, which is passed via ureter. Limitations, it may show increased renal calyceal pressure as there is no outflow of irrigation, and the stone-free rates are slightly lower, around 88%. It requires conversion to mini PCNL in 15% of the cases. Coming to mini microperk, to overcome the microperk's limitation, we developed a mini microperk where 8/10 French outer sheath is used for better manipulation and stability. And it can also utilize a 1.6 millimeter ultrasonic lithotripter, and baskets and fine forceps up to 3 French can also be used in this. Needle perk, just for completion, it utilizes an even smaller needle of 4.2 French. It may be indicated in pediatric patients. Just disadvantages do not allow stone extraction. This table depicts just comparison of standard mini, ultra mini, and micro PCNL. Important points are the standard PCNL and mini PCNL, they show very high stone-free rates. And there is a limitation of ultra mini and micro PCNL where they can utilize only laser lithotripsy. Super mini PCNL uses a 4.2 French telescope with an 8 French outer diameter, 7.5 French inner diameter sheath. And after an assembly, you can see there is a 3.3 French working channel. There is a special irrigation suction sheath where the gap between the two sheets is for irrigation, and the central lumen is for continuous suction of 100 to 150 millimeters of mercury. It is indicated in stones up to 3 centimeters and pediatric stones of 25 mm. And wherever there is unfavorable anatomy for RIRS, like infundibulum of less than 5 millimeters or more than 3 centimeters. Difference with mini PCNL is in stone removal. In mini PCNL, it is a passive removal of stones by a vacuum cleaner effect, while in SMP, a negative pressure is applied. Coming to latest updated miniaturization, that is Superberg. It was given by Shah et al. In 2017. It utilizes a special digital nephroscope, which is a pediatric ureteroscope of 4.5 to 6 French. And it consists of specially designed sheets with suction mechanism. In this diagram, we can see that the Shah super sheath has two components. One is the tubular metal sheath along with their dedicated metal dilators. And also there is connector. If the connector is detachable, it is autoclavable. And if it is not, then it is non-autoclavable. A stone catcher bottle consists of a smaller opening for suction machine and a larger opening for the sheath. In this, the energy source, we can use both pneumatic as well as laser lithotripsy, and the suction would create a negative pressure which will augment the vacuum cleaner effect. Important point is the sheath comes in different working lengths of 10 centimeters to 14 centimeters and different sizes ranging from 12 French to 24 French. Power of the suction is usually kept to 150 to 200 millimeters of mercury. This diagram depicts all the available sheets we have from 12 French to 24 French. And they have specific connectors which has been labeled as S, M, L, and XL according to the sizes. And they can accommodate different types of nephroscopes ranging from 12 French to 22 French size. Advantage of Superperk is it is easy to use and very ergonomical. In and outward movements of nephroscope is very easy. It is a relatively quicker process. Tubular surgery is possible. And for larger stone bulk, you can vary the sheet size and use a larger sheet size for stone removal. Continuous suction prevents the movement of the stone fragments into different calyces, and there is convenience of placing a stent under direct vision. This is a video depicting Superperk. After initial puncture, the surgeon is dilating the tract, then placing the appropriate size sheath, connecting it to the suction catcher. Then, with the help of the movement of the nephroscope, he's using a laser lithotripsy. With the movement of the nephroscope, the stones are retrieved. He's placing his left index finger over the vent to change the pressure of the sheath. This picture depicts the different sizes up to which different techniques can be utilized, like micro PCNL up to 1.5 centimeter stone, ultra mini up to 2.5 centimeter of stone, and mini PCNL, super mini PCNL, super perk, and conventional for even a stack-on calculus. Coming to flexible mini nephroscope, flexible mini nephroscope has a size of 7.5 French, and it can the smallest mini PCNL sheet can pass through. The length of the shaft is 45 centimeters, and a working channel of 3.6 French is available with a 270 degrees deflection of the tip. Advantage is we can utilize it in large bulk stones or different stones in different calyces, because entire pelvic calyceal system is easily examinable by this. Initial main bulk of the stones is removed by the rigid nephroscope, and followed by that we can do flexible nephroscope. Coming to endoscopic combined intrarenal surgery, this utilizes simultaneously flexible ureteroscopy as well as PCNL, and we can manage complex stones in one session. Advantages: there is no need of second sessions, better stone-free rates, lower complication rates. Only limitation here is we will require 2 endovision systems and 2 surgeons performing simultaneously, so a large space is required in the operating room. Mini ECIRS, it utilizes a renal access tract of less than 20 French, and the stone-free rate is 73.2%. This is the standard Galdakau modified supine Valdivia position, where you can see the patient ipsilateral side has been tilted 15 to 20 degrees to the opposite. The arm of the ipsilateral arm is over the chest. Ipsilateral leg is entirely extended, while the contralateral leg is flexed and abducted for simultaneous ureteroscopy as well as PCNL performance. Procedure is 6 to 7.5 French semi-rigid ureteroscope is passed and the ureter is visualized, following which 11-13 French or 13 to 15 French urethral access sheath can be placed, and the flexible scope assesses all the calyces before renal puncture. And endovision guided renal puncture is performed, hence it is helps in performing safe and desired calyceal puncture. Stone fragmentation is mainly via renal access, and retrieval is also via renal access. The ureteroscope is just performed for passing the ball technique, where the stone fragments are passed over to the instruments that we pass via the percutaneous tract. Micro ECIRS is just a modification which utilizes a 4.8 French all-seeing optical needle. Coming to the positions in PCNL, the entire timeline starts from 1976, where first PCNL was performed, and the position was classic prone position, which has evolved over time with original supine position coming in 1990, and also the latest Bart's flank-free modified technique, which was given in 2012. It gives the best exposure of the flank among the supine positions. Advantages and disadvantages of different positions are: classic prone gives excellent exposure to the lumbar area, but it requires patient repositioning. The Bart's flank-free technique gives the dependent access, which helps in spontaneous evacuation of fragments and less fluid absorption, and general anesthesia can be avoided with this. This is a flank-free position for PCNL. Coming to newer advances in access, major chunk of advances in PCNL has been in access because of development of technology. One such is integrated optical system in needle. This is like all-seeing needle where more secure renal calyceal entry can be performed. Advantages: we can see the appropriateness of entry site before dilatation, avoid colon injury. But the disadvantage is in the planning phase, we cannot see what is the accuracy of the calyceal that we have entered. Only after the entry, we are able to see that the entry has been correct or not. Eurodyna CT utilizes a large system which is either floor mounted or wall mounted. It takes around 396 images within 8 seconds by a 270 degrees movable sheet, through which 3D images are reconstructed, and with the help of a planning tool, we can plan our puncture. Access is performed by a bullseye method only, and the depth of entry is again checked by a fluoroscopy at 0 degree, which is one of the limitation of this procedure. The failure rates after initial reports are 25%. This is Eurodyna CT. A crosshair is developed via the machine, which will help us guide in the direction as well as the angle of the needle that we need. iPad assisted PCNL. This utilizes augmented reality. In a preoperative period, radio opaque markers are placed over the patient's body in the same position as the patient may lie in the operating table. And with the help of a CT and a software, 3D images are constructed and we can plan the calyx we need to enter. In the intraoperative period, we will attach the same markers, and with the help of an iPad, we'll be able to see the different organs, the desired calyx, the location of the stone. Coming to Saber Source. Saber Source is again a C-arm with a system for real-time imaging. It again utilizes a bullseye technique, and there is development of a crosshair here also, which will help us guide the needle in the desired direction as well as the desired angle. It consists of a needle collimator, which has a simple property. It has an opening in the distal end, which will light up when it is aligned to the desired calyx. Polaris technology uses an infrared camera. Under fluoroscopy, the images are taken just before surgery in 30 degrees, 0 degrees, and minus 30 degrees. And then the C-arm is moved aside and USD is used. So here we can see that with the help of augmented reality, the surgeon is able to see virtual images, virtual needle is there, which helps him in guiding the needle to the desired calyx. And we can see in real time the ultrasonography displayed on the monitor. This is surgeon performing this in the clinical scenario. The system utilizes i3D puncture system. This is a diagrammatic depiction where in the image B, you can see that there are coordinates X, Y, Z, and they should be aligned perfectly in the circle, green circle in the center for the desired calyx that has been pre-planned. 3D ultrasonography. In this, multiplanar images are already taken by 2D ultrasonography, and with the help of a computer, we design and create a 3D system for desired puncture. Ureteroscopic Doppler ultrasonography. In this, a Doppler transducer is placed over the tip of a ureteroscope. The ureteroscope is passed in the pelvic ileal system, and it delineates the blood vessel, blood supply, where all they are going, and we can avoid injury to the blood vessels. Real-time virtual sonography. The basic principle here is an electromagnetic sensor on the ultrasound probe. Here also in the preoperative period, MRI is done and DICOM images are taken. And in the intraoperative period, we utilize a USG probe with a special magnetic sensor and also a magnetic field generator. And in the image D over the right side, you can appreciate that fusion images are created, just like what we do in fusion biopsy. Fusion images are created and it helps us in guiding the needle. Sonics GPS. Sonics GPS is again a navigation-based technology. In this, you can see that in the image C, we see a machine which is a Sonics GPS machine, and there is a sensor in front of it which generates the field. And this field helps us in guiding the needle. The needle consists of a specially designed sensor over the distal part of it. And the probe of ultrasound also consists of a special sensor in it. When we place the ultrasound probe and guide the needle, you can see in the image D, there is a small white circle that is placed in the desired calyx. And there is a virtual image of a marker or a needle pen that is being entered in it. And it will buzz when you enter the circle, thus help in guiding the system. Electromagnetic tracking. It again utilizes a ferromagnetic sensor tip. There is a ureteroscope which consists of a ferromagnetic tip. It has been entered into the PCS, and also the needle consists of a special sensor attached to it in the distal part depicted by red. There is a aurora field generator which generates an aurora field in the intraoperative period, and with the help of a special software, we create 3D images and help in guiding the needle. This is a table depicting different advances of technology and what are their advantages and disadvantages. Coming to robotic assisted PCNL, it was first tried 2 decades ago without success in the Paki RCM robot. Then came AccuBot robot for renal biopsy. And in 2021, we utilized artificial intelligence powered robots, mainly the NTAC system. This is an NTAC system. It can utilize both fluoroscopy guidance access as well as USG guided access. This is the entire diagram depicting a stone in the upper calyx, the desired approach by placing a needle in the image B, and the system then generates a yellow circle within which there is a small yellow dot of the desired calyx that we need to enter, and it will guide the surgeon by placing a ring over the patient's body to enter the desired calyx in the desired angle. Coming to advances in lithotripters, major advances have been in combined ultrasonic and pneumatic lithotripsers. These were the slightly older ones with Swiss Lithoclass Master Ultra and the Calcusin lithotripser. They consist of a solid pneumatic probe plus hollow ultrasonic probe. The pneumatic effect is used for fast coarse fragmentation, while the ultrasonic is used for fine fragmentation and pulverization. And combination of these have clearance of stone twice as fast. The stone-free rates are more than 90% in PCNL and more than 95% in the ureteric stones. These are the new generation dual lithotripsers, mainly shock pulse stone eliminator and Swiss lithoclass. They have single lumen probes and a larger inner lumen, which shows more, even larger stones can be sucked out. Shock pulse stone eliminator, it utilizes both standard as well as high power mode. The only limitation of this is you cannot use ultrasonic lithotripsy and pneumatic lithotripsy separately, which was overcome by the Swiss lithoclass triology. It gives us an option to use either ultrasonic or mechanical or both energies. It can be used in mini PCNL with probes from 1.1, 1.5 and 1.9 millimeters available. This is the technology behind it. Over the right, you can see the standard ultrasonic vibration, and over the left, you can see the shock pulse SE technology, where in between pneumatic shock waves are taken, are given, by which faster stone fragmentation is possible. Cordless lithotripsers are the one which do not require any connection to it. They work on 4 AAA batteries, the litho breaker, which we see on the right side. This is just a table depicting the different probe types and the available probe sizes that we have with different lithotripsers. Advances in lasers. Major advances have been in development of Moses technology and the thulium fiber laser. Moses technology, if we see, Moses effect utilizes all the energy in the formation of the bubble, and the energy is totally absorbed by the water. To overcome this, we created a system that delivers energy in 2 bursts. The first burst is to form the bubble, and the second burst travels to the vapor and help in stone fragmentation. Using this technology, we developed high power holmium laser, which has a 120-watt high power system. It advantages shortening of the operative time and improve stone fragmentation efficiency. Thulium fiber laser. Thulium fiber laser has a wavelength of 1940 nanometer. It has a high absorption peak in water and better fragmentation, up to 4 times faster than holmium laser. It has the potential of a more cost-effective system with easy maneuverability. It can produce dust particles higher in quantity and smaller in size as compared to the holmium laser. This is a pic depicting the Moses technology and the thulium laser. Nanosecond electropulse lithotripter. It has been developed by Lithotech Medical Limited, which produces electric pulses of high voltages, which are delivered in nanoseconds, and it is transferred onto the stone. The great thermomechanical stress over the stone causes the fragmentation of the stone. The studies on PCNL is still pending. It has been utilized in ureteroscopy. New update in the operative model is the daycare system. The daycare system utilizes discharging the patient within 24 hours of the surgery or on the same day. Earlier, the limitation was the patients with a lower ASA scores, simple stones, and without any infection. But now we have extended the indications, and they can be utilized for staghorn stones after proper treatment of any infection if there. Thank you.
Thank you, Sarthak, for a nice presentation. Yes. So any resident or faculty has to make any suggestion or query, most welcome. If somebody who has joined us wants to say something, just please raise your hand. So we will, as usual, summarize the whole thing and then take up the MCQs, right? So PCNL, yes, it is very important for our department because our department was probably the first in the country to start PCNL. One of the first, if you want to say. So in 1985, Arthur Smith came first to Mumbai and then exactly the next day to Jaipur. And we started doing PCNL since then. And we have done almost 50,000 PCNLs till now in the last 40 years. Probably the largest series from a single center. So we are really proud of our center being in a department which probably was one of the first to start PCNL in the country and probably has the largest series. So when we come to the recent update, there have been various modifications in last few decades. We all know PCNL started, as he said, first Goodwin did kind of a nephrostomy, and then Johnson and Fernstrom in 1976. First, they did a nephrostomy, put a nephrostomy. They kept the nephrostomy for a few days. It was actually gradually dilated with increasing size of nephrostomy tubes. And the largest diameter nephrostomy tube was kept for 14 days. And then this was all done under local anesthesia. And then after 14 days, he removed the stones through that nephrostomy tract. So this is how the history began of PCNL and when the open surgery became almost obsolete for large renal stones. And then, yes, later in the 80s, Arthur Smith, who actually popularized it. And then in 1987, Valdivia started supine PCNL. And then in around 1997, the mini PCNL started. So that if we talk about the various modifications that has occurred, if you start from the imaging, whenever there is a large stone, we all know the basic indication for PCNL is more than 2 centimeter size stones, and particularly staghorn calculi. And then staghorn calculi are also divided into various types, type 1, type 2, type 3. I think you must know all these things about the morphometry, the nephrolithometry, the stone nephrolithometry, STONE, where the S for the size, T for the track length, O for obstruction, N for number of calyces, and E for the essence or the density of the stone. So this is again important, type 1, where the volume of the stone is less than 5,000 cubic millimeter, and the inaccessible calyces would be less than 5%, whereas type 3 is when the volume is more than 20,000 cubic millimeter, and inaccessible calyces where the stones are would be around more than 10%. And in between would be type 2. So these were certain things which actually help you to assess the complexity of the stone and try to prognosticate what would be the residual stone-free rate in these patients. And then the Guy's stone score, all these things came. When you talk about imaging, yes, NCCT is very important. And then if you do a CT urogram or a CT angiographic study, that actually will tell you the function of the kidney along with the vessels, where give a description of the vessels so that you know exactly what is the chance of bleeding through a particular calyx entry. And then they have developed also MRI imaging before CT, before this opting for PCNL surgery. So imaging has been, there has been a lot of this development. And then when we talk about the actual surgery, so miniaturization of the stone, PCNL definitely has been the major development. We all know about the various, the conventional PCNL being 24 and above, and the mini PCNL below less than 22 French, 12 to 20, and the ultra mini would be somewhere between 6 to 12. And then we have a micro perk, which is less than 6 French. They have an all-seeing needle, which they have developed. One is a 4.8 French, and the micro perk is 4.2 French needle. The basic disadvantage of the micro perk that you cannot remove any fragment. So they are usually utilized in pediatric patients and very small stones in other cases where you are not able to access. They can be used as a combined PCNL that with mini or conventional. So this was about the miniaturization. And then when you talk about the axis, right? So second comes the needle axis or the positioning of the patient. Positioning, we all know the first it was a prone PCNL, and then the supine PCNL came in 1987 by Valdivia, and there were various modifications, Geldekau's modification of Valdivia. And then in prone also there was a split leg prone position or the prone flexed position, where you can actually increase the distance between the costal margin and the iliac crest, and you can easily go to the upper pole axis. And then by putting the bolsters again in different kind of a way would help in different ways. So if you put the transverse bolsters, is usually will help to increase the distance. If you put the longitudinal bolsters, it makes the kidney more stable. So these modifications have been there in positioning of the stone, and we all know the ECIRS, which has helped in a endoscopic combined intrarenal surgery where you do both PCNL and RIRS together. Then coming to the axis, when we do, there has been a lot of kind of modifications. And the most important modifications would be, we all know the various techniques, the bullseye and the triangulation technique by which we do. There has been a lot of developments. One was the endoscopic guided needle puncture. Then they developed RIRS. Through RIRS, they would put ureteric catheter, which will guide into a particular calyx. And through that, you can pass a needle kind of a wire, which crosses the calyx and passes through the skin. And then you, over that needle guide wire, you actually pass the ureteric catheter or a guide wire or a dilator, and then you dilate the system so that you can achieve a very kind of accurate puncture through the calyx. And then came the robotic axis. We all know there are various robotic systems that have come up. And then we have various, we did first the fluoroscopy guided, then it came the ultrasound guided. A lot of people are doing ultrasound guided or a combined ultrasound and fluoroscopy guided. And there are people who do CT guided. So in West, there are places where they actually send the patient to radiology suite and they get the percutaneous access either under ultrasound or a CT guidance, and then they do the surgery. But CT guidance, they have a specific indications only, particularly difficult patients, obese patients, or ectopic kidneys or transplanted kidneys, horseshoe kidneys. They may require some time CT guided entry. They have also now developed MRI guided entry. When you talk about robotic, you talked about the AccuBot, and they have now come with an MR bot. MR bot is something where the MR, which comes in the form of a C-arm, and MR guided robotic access to the calyx has developed. This is called MR bot. And now we have AI powered kind of a robotic system, which actually helps to puncture. But whatever these kind of what my feeling is, because PCNL has a slight learning curve, right? As RIRS can be a very, very small kind of a very uh, not a long learning curve. So people are trying to get a lot of these kind of modifications to get access. But when we talk in our center, our residents are doing regularly the percutaneous nephrostomy, and we don't feel usually the need to take these all robotic access for the needle puncture. Then when we talk about dilatation, there were various ways. As we know, we have a telescopic metallic dilators, we have a facial dilators, we had balloon dilating system also. So, and then one-step dilatation or a three-step dilatation also. So these were the various modification in dilatation. And then when we come to the fragmentation of the stone, there are various sources, as he has mentioned, the ultrasonic pneumatic, the combined, the shock pulse, and the triology, and then the laser. All these are various modifications, the fragmentation of the stones. And then when we come to kind of a bleeding, which usually sometimes happen while removing the Amplar sheath, there have been various modifications in the form of either putting glue or sealant, or sometimes hemostatic gelatin matrix. All these have been utilized as certain things to reduce the bleeding from the tract. And then we had those modifications regarding whether to put a nephrostomy tube or not a nephrostomy. Then there was various studies showing whether it should be a thin caliber or it's a large caliber nephrostomy. So most of us now do as with a kind of a small caliber nephrostomy, either 12 or 14 French nephrostomy tube. And majority of mini PCNLs would not require a nephrostomy tube. That's a tubeless PCNL. And even now people, you don't have to put DJ stent in every case. So it's a kind of a complete tubeless, or that is called tubeless and stentless PCNL, where majority of these patients with mini PCNL can be done as a daycare surgery and can be sent the same day. So I think these were certain modifications, and where we had also a few modifications regarding if you have to put a DJ stent, usually you would call the patient for removal of the DJ stent. So there is another technique by which we do not do an ancillary procedure for removal of the stone. You can actually put a proline thread over the upper J of the stent, and that proline thread can be put outside the track, right? And when you want to remove the stone, just pull the proline thread and the DJ stent comes out. So that is another kind of a modification where you did not ask the patient to come for DJ removal. They can just come after 3 days or 7 days, and they can just pull the proline thread. So these were, I think, a few modifications, PCNL, and the super perk. Super perk, you said about, you showed the image of a kind of pediatric scope being passed through the super perk, but actual super perk has a digital nephroscope. We are using that digital nephroscope for the last couple of years, and that has made a huge difference. So digital nephroscope is as light as a pencil. You do not have any attachment over it of a camera, of a light cable, all those. So it makes so easy the whole thing. It makes the whole PCNL like it's very simple and very easy and less tiring, because the nephroscope itself is so light, right? And so you have different sizes of the nephroscope. And then one of the major modification has been the suctioning, right? And the suctioning is either by, as you said, by the whirlpool effect in mini PCNL or the ultra mini PCNL. And the other thing is by the SNP technique. SNP technique, where Zheng et al. Actually started this first, where with the negative pressure, you can actually pull the stone and remove it by suction, which is utilized in super perk. So suction has suctioning of the fragments and the dust has been a major advancement in PCNL in the last few years. So I think all this will make PCNL less minimally invasive. People have considered PCNL as the most invasive amongst ESWL, RIRS, and the other endoscopic surgeries. But definitely, these modifications have made the complications even less. When we talk about it from our center, I think we have done few studies, and the complications have been very few. I think injury to colon or visceral organ, I have never seen in last 30 years an injury to the visceral organ, like liver, spleen. Colonic injury in the last 30 years, I must have seen only around 3 or 4 cases in about 30,000 PCNL, right?
30,000.
In last 30 years, in my tenure. In my tenure, in last 30 years, I have not seen more than 4 or 5 cases of colonic injury. Then if you talk about bleeding and angioembolization, I don't think we require in every year maybe 1 or 2 or 3 cases, not more than that.
People who have been operated
Outside. So in our center, I don't remember when we did a last angioembolization, right? So hardly 1 or 2 in 1,000 cases which are being done every year. Right.
I think that's in PCNL, the major essence of AI would have been prediction of stone clearance.
Yeah.
Which we have lost big time, especially India, just because we were not able to give good data as far as stone volumes, punctures, and stone clearances. Because data keeping in India is because AI depends upon your data acquisition, data feeding,
Right.
and it depends upon how you are able to feed data into that AI program.
I think Nachiketa is trying to make a very important point regarding our centers, which are probably doing the maximum in the country. It's not only our center, there are many other centers which are doing a lot of PCNL surgery. And if you combine together, this would be the maximum in the whole world. So, but the unfortunate part is that we are not able to produce that data and publish them as it should be. And as he is making point of about AI, I think Dr. Nachiket make that point.
I think as far as PCNL goes, is the most important point for the patient also and for the surgeon is about residual stones. And now a lot of work is being done inside US and also inside Europe about finding out how AI would be able to tell you about what the instance of residual stone in a particular patient would be. So if you look at the different triangle of how AI works, and first of all, you have to acquire data, you have to analyze the data, you have to feed that data. The machine or that program will then quantify the data, then it will give you a result. And then there is something in the last which is known as language programming, and basically it is just the result. So the problem with our country is that we have not been able to store good quality data. We have not been able to keep that data. We have not been able to analyze that data. That data is fudged. So even now for things like stone disease, in which we are the leaders, just say India and China, I believe, they are the leaders of stone surgery in the whole world, but still we will be dependent upon the West to give us AI programs. And this was the reason. Now, 15 years back in the US now has removed the capping on keeping data in hospitals, because they realize now that they have to use this data which was in the hospitals, and they have to give this data for making AI more smart and to generate better AI programs. Pehle, in non-medical legal cases, US may you just had to keep data for 5 years, and inside medical legal you had to keep them for a minimum of 10 years. But now the US has removed that capping, and because there was a problem of even storing that data. But now storage is also with better cloud storage and with cheaper cloud storage and with better servers. So even the problem of storing data that uses high amount of storage volumes has removed. Now in our department, we I think have done all type of stone surgeries, but the only problem is that we've not kept that data and we have not been true to the data. Had we been true to the data, then maybe this AI programs of stone clearances would have come from our department. But unfortunately, it's not going to be that way. And now I believe that in Johns Hopkins, they have come out with an AI program about stone clearance, both by PCNL and both by RRS. So it helps you also to talk with the patient that, okay, this is the data that we have for 20,000 patients. And if I use this modality, this puncture, then your residual stone, volume is going to be this. So I think that it's unfortunate that we're still going to, depend upon those countries for things in which, India and China, like people we have been pioneers at.
Yeah, I think so. We are at fault. Though we have produced a few studies on PCNL, we have been published. We have published it also, and now also we are doing some studies, and we are trying to collect the data on PCNL, etc. But definitely, we have to admit that we have not been able to produce a very good quality publication in last few years. But anyway, yes, we are doing it. The USI is also doing it. They have their collaborative research team. I'm also part of the member. We are trying to do some multi-centric studies, and we must do. I think this is let's have a kind of a lesson from this class only. Let's do some. Yeah.
What we are doing,
Yeah.
not just make up the results, not punch the results.
Right.
Make sure that we,
That is true. That is true. I think that is everywhere. You are trying to let's not undermine ourselves that India or China or any of these countries are doing a lot of this. Even the Western world is doing it. Almost 80% of the data is actually not genuine throughout the world. But anyway, yes, we have to collect data and in a particular, in a very genuine way, and we should produce that data. I think anybody, if you want to say anything, Neeraj, if you want to have any suggestion, please let me know, and then we will.
One of the things in PCNL is that it's a very heavily technology dependent or instrumentation dependent surgery. So I think to get optimum PCNL results, we should have all types of armamentarium, whether it is a mini PCNL, we are having super work in our department. We also should have laser, already have a laser. We should do Sarthak's seminar was on miniaturization of track. I mean, till recently, I believe we were all doing standard PCNL only, dilatation up to 30 frames, 30 frames, even for stones, small stones, we were doing 30 frames dilatation. So I think we should
Move ahead
all
with that.
types of PCNL.
Yes.
From mini PCNL to ultra mini to standard PCNL and then come out
With the data. I think in the last 3-4 years, we have been doing a lot of mini PCNL, super bug. We have been doing all kinds of PCNL. We have tried supine PCNL also, and we have done it successfully, various supine PCNLs also, but we didn't see the need for doing supine. That's why we have not been able to do a lot of supine PCNLs. But yes, I think we should do a little more of supine PCNLs and ECIRS also, a combined retro. We have now intrarenal kind of a flexible ureteroscope. We should do, I think, combined intrarenal surgery. So coming to our next part of the seminar, which is the very MCQs. So which of the following statements is false regarding super perk? Different sheath sizes are available. Only laser lithotripters can be used as energy source. Continuous suction can prevent migration of stone, and stent can be placed under direct vision. So all of us know that this is B, where we can use the pneumatic lithotripter also in most of these super perks. We can use both laser and pneumatic, and definitely it comes in various sizes. You can do a conventional PCNL with the super perk also. So there are various scopes available, and I think this is a great invention by Shah, that digital nephroscope, which is so light and so easy to use. Second is all of the following are advantages of ECIRS except reduced need for second sessions. ECIRS has better stone free rates. Complex stones can be managed in single setting, occupies less space of operating room. So definitely it occupies more room, definitely, because there you have to do combine together. And definitely complex stones can be done because you combine the two methods. iPad assisted PCNL is a great leap forward in technology. All of the below statements are true except preoperative CT images are taken and reconstructed images developed using MITK software. 3D images are displayed intraoperatively. Target organ involvement movement leading to a target loss is a limitation. It utilizes augmented reality. So it's B because 3D imaging is not possible in iPad. You have always a 2D image, right? Otherwise, you need to have a preoperative CT image. It's actually augmented reality, the form that you take a pre-op CT and then you superimpose it over it. Target organ movement is a limitation. Achha. Okay. A very interesting thing told by Dr. Nachiket that the invention was by daughter of Ras Wheeler, who's a famous Marie Ras. Yeah. So this is about the iPad system and the true statement when comparing thulium laser to holmium-Yarg laser. Thulium laser requires less heat dissipation and can operate at high power and high frequency images. Architecture of fibers lasers is insensitive to shock-related damages. Unlike holmium laser, thulium is forced air cooled, while holmium-Yarg is water cooled. All the above are true. All the above are true, I think. Yes. So all the above are true. Which of the following is a shortcoming of supine versus prone PCNL? Prone PCNL is safer when compared to supine PCNL. The length of percutaneous tract is longer in supine. The radiological hazard is higher in supine. Repeated C-arm positioning in and out of operating field is required in supine PCNL during puncture. Is it the radiological hazard? Yeah. Is less in supine PCNL? No, you want, which is true, you want to say? Shortcoming, because this is a longer track. Yes. So supine PCNL has definitely a longer track, and it is a little. It's shortcoming because they may usually the shorter the track, it's more stable and easier. Definitely. So because PCNL has a shorter track, kind of a stable track, the dilatation is also very kind of better while doing prone PCNL than supine. So these are certain short limitations of supine PCNL. Then there are various advantages also. Yeah.
Prone PCNL is safer as compared to supine PCNL.
So it is. Yeah. So shown to be equivalent. Yeah. Yeah. So a non-negligible shortcoming of the supine decubitus is the greater length of the percutaneous tract. This depends on the fact that the puncture is more lateral and the relationship to abdominal wall is different. From effectiveness and safety point of view, it has been widely shown that supine and PCN prone are equivalent. In addition, the radiological hazard is reduced because the surgeon's hands are never directly under the X-ray beam. So in that way, it is advantageous over prone PCNL, and ergonomics also favors supine PCNL. Owing to the direction of the axis, there is no conflict between the instruments and the C-arm, so that the annoying movement of C-arm into and out of the operative field is never needed during the procedure. And then the stones come out by gravity. So that is again another advantage. The patient is kept supine. So from anesthetic point of view, the advantage is there when we talk about the respiratory and the cardiac issues. I think, thank you. So that was all about. If anybody has anything to, yes, if you want, anybody has any question, anybody to, so okay, thank you. Dr. Manoj, would you like to just sum up? I would ask the moderator, Dr. Manoj, to kindly come and give his last remarks.
Thank you all of you. Very nice presentation by the Dr. Sarthak. And discussion about the patient, sir, Nachiket sir, and Neeraj sir. Thank you very much.
Thank you. Thank you, everybody. So I can see Naresh. Would you like to say something, Dr. Naresh?
Sure.
Yes, go ahead. Okay. Would you like to say?
No, sir. No, sir. No, sorry. Sorry,
Okay,
sir.
thank
you. Unmute.
Thank you once again, and have a good day, all of you. So all of those who might have joined us today on Zoom or YouTube,